Good afternoon, everybody. Today's webinar is on public health, genetics, and genomics. We are pleased to have two certified genetic counselors with us to present this webinar. And it is my pleasure to introduce my colleagues, Amy Gaviglio, who is a follow-up supervisor, genetic counselor, and the Minnesota Department of Health Newborn Screening Program, and Beth Vogel, follow-up supervisor at the New York State Newborn Screening Program, and also the project manager of the New York Mid-Atlantic Consortium for Genetic and Newborn Screening Services. Before we begin with today's presentation, a few housekeeping items. Kindly comment and put your questions in the question box that you see in the control panel. We'll try to address as many questions as possible, and if we could not address all, we'll send summarized responses from our speakers to all attendees today. Additionally, the webinar will conclude at 1 o'clock. Since we have another project educational program with the genetic counselors and LENT trainees, we request them to stay online and do not disconnect. Once the webinar concludes, you'll be directed to a link for the evaluation survey. We greatly appreciate your input to help us improve our educational activities and make sure that we attend to your needs and requests. So on that note, I invite Amy Gaviglio to present today's webinar on public health genomics. Thanks, Amy and Beth.
Perfect, thank you. Can you hear me okay?
Yes.
Okay, perfect. You can go to the next slide. All right, so we've listed here the learning objectives for today's webinar. And so at the end of today, hopefully, if we've done our job, you should be able to illustrate examples of roles of genetic professionals in the realm of public health, discuss integration of genetics and genomics in different public health programs, describe how genetics and genomic activities fit within the essential public health functions, as well as review or at least be aware of NSGC, so the National Society of Genetic Counselors, Public Health Special Interest Group efforts. So next slide, please. Okay, so for my portion of today, I will be covering kind of the following 4 points. I would like today to be as interactive as possible, so please do feel free to interrupt me with questions at any time. I know that can be a bit awkward on a webinar, but please do chime in as you need or want. So I'm going to start with kind of a very broad and brief overview on what public health is, and then move on to how genetics and genomics fit into the concepts of public health. We'll review the various different roles of genetic counselors in public health, and then hopefully discuss some opportunities that you can take on or solicit that if you're interested in genetics and public health. Next slide. Okay, so before we can delve into really the genetics and genomics part of public health, we should get on the same page as to what all public health encompasses. So next slide, please. Okay, so what is it? And you can click through all of the animation here, sorry. Often, I think the first concept that people think of when they think of public health is the concept of prevention. Preventing disease, preventing accidents, kind of et cetera, et cetera. However, public health really extends far beyond the concept of prevention. It includes policy development, addressing health inequities, surveillance, and building of infrastructure at various levels, whether that is at the community level, at the state level, maybe the regional level, or the national level. I've included kind of two of my dorky favorite quotes regarding public health that I really think help exemplify what public health is all about. So the first one is by C. Everett Koop, which really talks about healthcare being vital to us at some time, so when we're sick or when we need to go in, but the concept that public health is vital to us all of the time. So public health is kind of always there, always behind the scenes, always trying to make things better, or prevent things from happening. And the second quote is also one of my favorites because I think this is is really pertinent to genetics and genomics in particular, but the concept of public health is the persistent redefinition of the unacceptable. And so continuing to look around and thinking what is unacceptable when it comes to health, public health, genetics knowledge, ethical issues. So this is really a kind of a fun way to think of public health as that consistent redefining what the unacceptable is. Next slide. Okay, so let's start with the concept of prevention, because as we mentioned, that is a big component of public health. In prevention, in and of itself, is a spectrum of activities targeting both the individual as well as the population as a whole. So you can see, and I won't go through this, but I do believe you have these slides that really there is a huge spectrum of prevention that can really span the gamut of a variety of activities. And what we'll hear later on today is that genetic counselors have really found themselves throughout this spectrum. Next slide. So outside of the spectrum of activities to address prevention, which we saw in the previous slide, prevention itself can be targeted at the primary, secondary, or tertiary level. So primary prevention, I think, is often, again, what most of us think about with prevention is aiming to truly prevent the problem by taking action before the problem arises. So a very proactive approach. Generally speaking, in public health, this is aimed at populations, not just individuals, with the idea that anyone who is exposed to the preventive measure benefits from that action. So some global examples of this within public health are, of course, hand washing initiatives, immunization programs, public sanitation, universal seatbelt use, clean air laws, and as well as GINA, which is the Genetic Information Non-Discrimination Act. So this is actually a policy, but certainly surrounding the concept of genetics and genomics. Next slide, please. Secondary prevention is kind of the space where I personally spend most of my time. In secondary prevention, the disease itself is already present, or an individual already has an increased risk for the disease. So the goal is different than primary prevention in that it is to actually detect the disease and treat as early as possible in order to reduce morbidity and mortality. So where I spend most of my time is newborn screening. This would qualify under secondary prevention, as do many of the cancer screening, the population cancer screening programs, so mammography, colon cancer, as well as mental health screening, and cardiology-related screening. Next slide. All right. And the third kind of tier of prevention is tertiary prevention. So this is further downstream, obviously, from secondary prevention, in that this is used to target individuals who already have overt disease symptoms. And so the focus here obviously isn't so much on prevention of the disease itself, but more on prevention of the progression of the disease. So focusing on reducing further complications. So some examples of this can be early intervention programs for developmentally delayed children, organ and bone marrow transplants, cleft lip palate repair, and kind of broad scale use of insulin for diabetes. All right, I believe we have some poll questions for you, so I'm going to pause and let that happen. Perfect.
%80 voted. We'll give a few more seconds.
Okay.
Well, it seems that everybody agrees that it's a multidisciplinary field. Shall we go on to the next poll?
Yeah, that's fine with me.
Few more seconds. It would be interesting to learn, how you think it would help in addressing health disparities, or how will it not, or why it does not help with addressing health disparities later during the discussion. So thank you for the full responses. One more to go. I'm so glad with these responses. Yes, public health genomics is not just limited to cancer conditions. So thank you for the responses. And Amy, I think this poll questions responses were fairly intuitive. Please guide us through different roles of genetic counselors in public health settings.
Perfect. Sounds great. Okay, so if you can go to the next slide, please. Perfect. So now that we have talked a little bit about the foundation of public health and the various levels of preventative activities, let's now take a look at where genetics and genomics can or does fit into public health, and especially where genetic counselors and geneticists can contribute to that discussion. So largely for the purpose of today, I'm going to focus primarily on the concepts of ELSI. So ELSI stands for the ethical, legal, and social implications of kind of various research. So the concept of ELSI and its importance in this domain really came out of the Human Genome Project, where at that time the National Human Genome Research Institute was established in order to really ensure that as we were not only looking at the advancements of technology in genetics and genomics and at the population level, that there was also an ongoing incorporation of thinking about the ethical, legal, and social implications whenever there was research into this domain. So if I can get the next slide, please. So what does ELSI look at in kind of public health, genetics, and genomics? So here are some examples. This is by no means an exhaustive list, but some of the research that's been looking at public health genomics and genetics, particularly around ELSI, has looked at certainly fairness in the use of genetic information, privacy and confidentiality, that is a giant one. Certainly psychological impact and stigmatization. This is also something that's been very important to look at, especially secondary to historical misuses of this information. Reproductive issues, kind of uncertainties. As many of you are probably familiar, genetics, while it can provide you a lot of information, it can also provide a lot of uncertainty in that we don't always know what the mutation means. So how do you deal with that ambiguity, as well as things like commercialization and direct-to-consumer marketing. Next slide, please. So when one applies the concept of ELSI to public health, the application or the focus kind of inherently needs to shift a bit than what we think of in the clinical realm. So whereas in that clinical arena, the focus is largely on the individual patient, in public health, we really need to expand and look at the collective welfare versus the individual autonomy of the individual. And often, this is not easy because the individual autonomy may or may not be in accord with what is in the best interest of the population. And so when we're looking at ethical issues around public health genetics and genomics, I would say we rely a lot more on kind of those collective ethical theories in terms of examples of utilitarianism or communitarianism, which is really looking at kind of the good of the population over maybe the immediate good of an individual. Next slide, please. So likewise, when looking at principles of informed consent, and this is something that we'll, in my portion of this talk, we'll talk a little bit more about, is that in public health ELSI issues, there may be more of a limitation on the principle of informed consent. So typically in the realm of genetics and genomics in the clinical arena, informed consent is really the foundation of, of how you move forward. The informed consent process is fairly robust, not only in just, if you're going to be doing the test at the clinical level, but certainly for health-related research as well. So this is really expanding the concept of informed consent into looking at whether it is needed at the group level, whether the risks outweigh the benefits for the population. And so again, getting back to that concept of, where does informed consent fall into place with public health? Is it at the individual level? In some cases it may be. Or is it more at a population level where the decision to participate may or may not be made on an individual basis? And I will say that certainly this is an evolving concept, and there has been a lot of discussion and a lot of work around the idea of informed consent in the public health domain, especially around genetics and genomics. Next slide. The other thing to think about, and again, this isn't probably too out there for anyone, but certainly when we're looking at genetic information, that the outcomes of the genetic information obviously expand, or often expands beyond the individual, and certainly has implications for family members and potentially beyond family members. So where we start to see a lot of these ethical issues is, who is the patient? Should private information be shared for the common good? And really looking at how this information can be used to potentially address certain health inequities, or how we can maybe better serve certain populations by understanding different treatments that may work best in that particular group. So these are some other issues within public health ELSI that we're really seeing kind of come to the forefront. Next slide, please. Okay, and again, this is probably the area where I spend a lot of my time as well, in particular with newborn screening, is the idea that many public health programs, and newborn screening is an example of that, are mandatory in nature. So there is a disconnect from what we typically think of in the clinical realm of that concept of patient autonomy, where someone is sitting down with you, explaining the test, and you're making the decision whether to proceed or not. That kind of protective role of the state in looking at the potential benefits for screening at the population level versus what have been considered to be fairly minimal risks, is really kind of the hallmark of public health policy in general, but especially for newborn screening. So this is going to, I know we've had in our community quite a bit of discussion around the mandatory nature of newborn screening and how, how that may need to shift as we start testing for more and more conditions that maybe didn't meet the previous kind of paradigm of what we would like to see with newborn screening conditions. So this is going to remain an issue that needs more and more thought and activity around to really look at issues related to informed consent. And if we do think we need to go the route of informed consent at the population level, what is the best way to achieve that consent on such a broad scale? Next slide. And I guess I will pause here for a couple more poll questions.
Almost 80% voted. Okay. Amy, any thoughts on the results?
Well, since I'm a follow-up person, I'm glad that that is leading the way. But no, I think this is actually great. It's great to see that it's split because these are all valid roles. So I'm glad to see that they're all being selected as potential roles. So that's fantastic.
And I've seen the slides, so I look forward to your next couple set of slides. But we have one more poll question.
Yep.
A few more seconds. What do you think of this poll, Amy?
Perfect. I think we've got a very smart group on our hands. No, I think this is spot on. I would say that the first two that have 100% are certainly where we see quite a few genetic counselors, and certainly we're involved in grant writing and administration as well, but it's appropriately less than a lot of the other work we do. So I would say this looks great.
Thank you all for your responses. We'll learn more about the roles now. Thanks, Amy.
Yeah, no problem. I will go to the next slide. And you can just, go through. Perfect. So I've put together a fairly exhaustive list, I think, of the various roles that genetic counselors can or have taken in public health, specifically around genetics and genomics applications. For the purpose of time, I'm going to go through these rather quickly, but I do believe you have the slides, and I'll have my contact information at the end as well. So if you want me to expand on any of the roles, please don't hesitate to ask. So the first one is what I kind of consider the honest broker role. And so this is really looking at how to address certain issues. Informed consent would be a great example where the genetic counselor may take the role of convening stakeholders, making sure that the information is presented in an as unbiased way as possible, and ensuring that various perspectives, whether it be from the researchers, the health department, the public are being represented. So the kind of green text are examples of this, and Beth is actually an example as the one of the project directors for NIMAC. So if you kind of look at each slide, the brown will be an explanation of the role, and then the green will be actual tangible examples of genetic counselors in that role. So the second and third bullets are consultation and technical assistance and education. So many states do have state genetic coordinators whose role is to look at policy and put together programs to address genetic issues often at the state and or regional level. So this involves quite a bit of policy work as well as providing technical assistance to various programs, providers, and families. Certainly education is a big component as well. Genetic Alliance is a great example of an organization that employs genetic counselors whose focus is largely to increase, I guess, genetic-related health literacy and be a patient advocate portal for better understanding genetics and building that capacity both in the workplace but as well as the public domain. Next slide, please. You can go through again. Yep. So here we talk about coordination. So certainly we see quite a few genetic counselors in maybe disease-specific advocacy groups. So again, coordinating maybe programs for specific disease groups, providing services, coordinating people around genetic issues in terms of what needs to be done, whether it is policy, whether it's care coordination, et cetera. I think we're seeing a lot more of this coordination on social media as well, with genetic counselors serving as subject matter experts in many cases. Genetic counselors, even within the public health realm, can also provide direct service. So this could be if they are working in public health and genetics clinics or labs, other clinical or lab settings. So certainly in my day-to-day role, I on occasion provide direct genetic counseling to families with positive newborn screening results. Generally speaking, it is over the phone, but it is considered kind of a direct service role for genetic counselors. Next slide, please. Oops, there we go, perfect. I think assessment, policy and planning is where I think we really see that work being done to look at addressing health equity or health inequity in genetic services. And I don't know, Beth may speak to this as well, but this is a big movement within the kind of regional and public health genetic services collaboratives is to address access to care and health equities in genetic services. So I think this is where we're going to start to see even more of a role for genetic counselors and really looking at how we can get at-risk populations of kind of all shapes, colors, sizes into genetics clinics and getting them the care that they need in the most culturally sensitive way. So certainly I think this assessment, policy, and planning are going to be increasingly big roles for genetic counselors in public health. And next slide. Okay, finally, evaluation and research. So again, as we implement different programs, as we look at how we're addressing maybe health inequity in terms of access to genetic services, we have to do evaluation. Are the programs, are the techniques that we're putting into place actually making a difference? Is it what the community actually needs? And so we're going to see, again, I think a lot more in the realm of evaluation. There's a variety of different groups that work on this. I'm kind of sorry for the alphabet soup on here, but the third bullet is the Secretary's Advisory Committee for Heritable Disorders in Newborns and Children. So their role is to really evaluate the need to screen for new disorders in newborn screening, as well as the effectiveness of screening for the current disorders. And then, of course, research, again, which I think falls in line quite a bit with evaluation, but as technology continues to advance, more research will be needed on what individuals actually are looking for when it comes to genetics and genomic information. Next slide. So this is a quick map of the regional collaboratives, and I think Beth will speak to this as well, but this, in my opinion, is a fantastic way to get involved in discussions around what is needed for what is needed in the realm of public health genetics and genomics. It has really expanded to quite a great community of discussing what you need in your certain population. So I just wanted to put a shout out to the regional collaboratives. We are happy to give you more information if you're interested as well, but certainly for genetic counselors, we'd like to see more engagement in the regional collaboratives as we continue to address needs around public health genetics. Next slide. All right, I'm gonna, I don't know if I have how much time I have left, but to wrap up, I guess I'd like to walk through an example of kind of a current issue we are facing today, and I'm gonna focus on the issue of informed consent, but you can see we have quite a few issues for genetic counselors to address in kind of my role of newborn screening. So next slide. So let's talk a little bit about informed consent. You probably have heard it called a number of different things, but often it is more or less referring to the same concept. Next slide. Informed consent, I think what we deal with a lot is the fact that there are kind of two different ways to look at informed consent. There is the legal way, which is essentially a very discrete event of obtaining legal approval. So this is where you're really just looking for a signature without really looking at the process of informed consent. The ethical component, or the kind of the ethical definition of informed consent, really focuses on the fact that it is not just the end product of the signature, but it's really the process of making sure that the individual is indeed as informed as possible and is making a decision based on all of the relevant information. Next slide. So within newborn screening programs, as I mentioned, they are often mandated by the state, but they're considered opt-out programs, which means the default essentially is that it will have, the child will get screened unless the parents choose otherwise. It varies state to state on what opt-out provisions are in place, whether you can opt out simply just for religious reasons or for kind of for any reason. So next slide. So here's a scenario, and I'd just like you to kind of read through it and think, kind of think about what you think about the situation. And then, Kunal, I don't know, do you want to go through these questions, or should I just kind of walk through them really quickly in the interest of time, and we can discuss after?
Yeah, I think we can go through the questions for the benefit of the audience, and we can discuss it in details with the trainees after the webinar. And just a quick announcement, all participants will receive the slides after the email. I'll make sure I'll email the slides to everybody. Thank you. Perfect.
Okay, so I have, if we go to the next slide, I've just put some questions, kind of food for thought. After reading this case scenario, do you feel that refusal of the screen is justifiable? What are your thoughts on whether the law should mandate newborn screening over parental objection? So there is at least one state who does not allow parents to refuse. Kind of what do you feel about that? And then how at a kind of state program or at a population level should refusals be managed in practice? Should they be followed up on, or should they just be taken as kind of at face value as the parent refused? Next slide. So this is kind of it's not a new problem. Newborn screening has been around for quite a long time. It's just the concept, I think, of informed consent is ever growing as it relates to newborn screening. So many people will ask me, well, why hasn't it been implemented? And I would say largely it is because in the past and until very recently, most of the conditions that we've screened for, the benefit, there is a very clear benefit, and that benefit is thought to substantially outweigh any risk associated with the heel stick. It's also interesting that most health professionals do believe screening should not be a choice. They see it as a standard of care, and that an individual or a mother really essentially consents to having it done when they kind of sign that broad consent for care upon admission. Certainly, as many of you are probably aware, individual informed consent is a very time-consuming process, especially when you're talking about genetics in a very complicated field. And so trying to do this at a population level can prove exceedingly burdensome. There is concern that minority populations may be missed if there are not individuals available in certain populations, or if you don't have translators available to perform the consent process, that they may miss the opportunity to have screening. Next slide. So these are a few other questions. Again, just food for thought. You can go through them. So I won't read through them, but we can certainly talk more about refusals and informed consent as they relate to newborn screening. So next slide. So I will just kind of wrap up with why I strongly believe that genetic counselors make great public health individuals. I do think we do have a training. Our training is often as open communicators and making sure that we are providing as much information as possible and in as a non-directive way. So I think that really bringing everyone together to the table to make the best decisions is kind of in our nature. We also are trained to explain difficult concepts, which is the concepts of genetics and genomics, especially at the public health level, are exceedingly complex. So just being able to condense that down into kind of lay or plain language is another great reason to have genetic counselors in public health genomics. Next slide. So as far as opportunities for you in terms of public health genetics and genomics, as I mentioned, the National Coordinating Center, so those are those regional programs, that map that I showed. Certainly the National Society of Genetic Counselors Public Health Special Interest Group. We are working on a few projects, so developing curriculum for genetic counseling programs to make sure that programs have the tools they need to make sure that genetic counselors understand all of the various roles within public health, as well as helping out with projects or providing projects for students who are interested in public health genetics and genomics. I did also want to mention that there is a public policy committee, so if you're more interested on the policy side of things, that's actually a fantastic committee to be involved in as well. And with that, I will pass the torch on to Beth, but here is my contact information. Feel free to contact me at any time.
Great, thank you, Amy.
Beth. Just pulling up the slides. Here we go. Thank you, Beth.
Thank you, Kunal. Good afternoon, everybody. Thank you for taking some time to join us this afternoon to talk about genetic counselors in public health roles. I'm going to go through some similar information to what you heard from Amy, and then pull in some examples from my own work that's also being done by our colleagues across the country. So we wanted to provide you with a couple of different perspectives and experiences related to what genetic counselors are doing in public health roles. So the learning objectives that I'll address today are illustrating examples of roles of genetic counselors and genetic professionals in the realm of public health, as well as describing how genetics activities fit within the essential public health functions and expanding the scope of genetic professionals. Next slide, please. So my public health experience, I'm the follow-up supervisor at the New York State Newborn Screening Program, and then I'm also the project manager for the New York Mid-Atlantic Consortium for Genetic and Newborn Screening Services, which is a regional genetics collaborative funded by HRSA. Next slide, please. So there's several different roles that genetic counselors can have in public health. I starred the two that I'm most involved with. So that's education of the public and or healthcare providers, as well as population-based screening programs. But other roles include lobbying in public policy, public health-related research and grant administration, as well as state chronic disease programs. So today, during my time, I'll go through those examples and talk about specifically what that work would look like, and then give some examples of work that I've done or that my colleagues have done that fits into those roles. Next slide, please. So there's several different settings where the work can be done, including state health departments, which is where my current role is. And this is an image of the New York State Department of Health offices in Albany, New York. University medical centers, universities, private hospitals, and diagnostic laboratories. So there's a wide variety of settings and roles that genetic counselors can participate in that's involved with public health. Next slide, please. So the education piece is really important and a key piece of public health as a whole, including conducting training for providers. So for example, when a new condition is added to the newborn screening panel, training providers on what to expect from the newborn screening panel for that condition is an example of that role. Presenting information to the media, publishing data in peer-reviewed journals, providing community lectures, creating advertising tools, publishing data in lay publications, assessing educational materials and creating educational materials, and making sure educational materials are at the recommended 6th to 8th grade reading level, which actually now we're even starting to hear they should be even lower than that. Next slide, please. So this slide has a lot on it, but I wanted to pull together some examples for you of genetic counselors that are putting together educational information for parents, providers, and the public. So in the upper left corner, that is a magnet that shows the role that NIMAC has in providing education. And right underneath that is actually a NIMAC and New York State Department of Health product that is a guide for patients on whole genome and whole exome sequencing from the Understanding Genetics series. We collaborated with the Genetic Alliance on putting that together. So that's on our website and available for anyone to download and use as a fact sheet. The NIMAC Facebook page is also in your lower left corner. The NIMAC Facebook page has a variety of audiences, so there may be posts targeted at geneticists, at genetic counselors. There may be posts that are intended to provide information for parents, because all of those different audiences are accessing and using the page. In the upper right corner is an article that I am not an author on, but was a great example of genetic counselors' role in public health, publishing about genetic counselors and health literacy and the role of genetic counselors in developing a web-based resource about the Affordable Care Act. So that's actually a different regional collaborative, the Western states, that worked on putting that publication together. And then in the lower right corner is an information booklet about newborn screening for X-linked adrenoleukodystrophy, information for parents. X-linked adrenoleukodystrophy is now a condition on the recommended uniform screening panel. So creating those materials on a complex genetic condition is a role that can be taken on by a genetic counselor working in a public health setting. Next slide, please. Okay, so population-based screening programs, as Amy talked about, genetic counselors are a good fit for working in newborn screening programs. Some of the traditional responsibilities include interpreting screening results, notifying providers of the test results, as well as parents and patients, and then coordinating the screening programs. So all of those different pieces of the system. Oh, go ahead, Kunal, you can go to the next slide. So I wanted to give an example and walk you through what my experience has been with newborn screening for adrenoleukodystrophy. So New York State was legislatively mandated to begin screening for adrenoleukodystrophy. I was working in my current role at that time, and so starting kind of from the ground up with test development and implementation. To start screening for a new condition, you need samples from individuals who have the disorder. So going through the IRB process to be able to get consent to test those stored dried blood specimens for ALD, working with the advocacy organizations to try and identify parents who have a child with ALD born in New York, and then talking those parents through the consent form and getting their permission to use the stored dried blood spots was a part of my role. Working on developing our reporting mechanism. So what will the final test result look like? What information do we want to share with the healthcare provider who will be reviewing that test result? Short-term follow-up is once the screening actually starts. So that includes notifying the healthcare provider of patients' screening results as well as the parents and patients. I showed you an image of the educational brochure that was put together as an example. And then long-term follow-up is collecting data after a child has been diagnosed with a condition on the panel. So what data do we want to collect and what would be useful in helping decide how to best care for a patient going forward. So my role with that was really with interacting with specialists in adrenoleukodystrophy to get their input and then putting that information together to move New York State forward with long-term follow-up for adrenoleukodystrophy. Next slide, please. So some additional roles, I won't go through all of these, but you'll have them on the slides. But face-to-face contact with families, Amy mentioned, is not a very common occurrence, but telephone contact can happen more frequently. And then working on some of the more day-to-day operations of a newborn screening program, like unsuitable specimens and sample collection. So I'm happy to answer any questions on those either now or after the fact if you take a look at those slides. Next slide, please. So lobbying and public policy, serving on a committee focused on the delivery of local, state, and national healthcare or genetic services. A lot of genetic counselors work on delivering services in those realms. Communicating with the press and media is an important role. We've seen a lot of genetics in the news over time. Public policy, assessment of state genetic resources and helping to determine future goals and strategies, providing comment on policies for insurers and payers, as well as communicating with senators and representatives. So I've got just a few examples of those on the next slide. So on the left, you have an article that was a NIMAC product in the Exceptional Parent magazine. That's what insurance doesn't cover for children with genetic conditions. So we conducted a survey of parents of children with genetic conditions across the region, asking about coverage for their child's healthcare needs, and then looked at that data and put together a final article describing what the gaps are for those individuals. So that can serve as helping parents and advocacy organizations to have data to back up their efforts. And then you can see a publication about sickle cell trait screening of college athletes and reasons for ethical reasons for program reform. So this is, again, not a publication that I'm an author on, but it serves to show a role genetic counselors can have, that the NCAA recommended and required sickle cell trait screening for all of their athletes. And many newborn screening programs felt the effect from that, from athletes requesting results from 18 plus years ago from the newborn screening programs. And as you can imagine, there were many ethical issues related to that as well, and newborn screening programs encountered that as well. And these authors who are genetic counselors helped bring that issue to light and hopefully bring about some reform. And then finally, in the lower right-hand screen, as part of the funding for the regional collaboratives, we were asked to do a needs assessment, looking at the current genetic needs in the region, and a final brief was put together with that information. And you can see the front page of that on your screen. Next slide, please, Kunal. So public health-related research and grant administration can be another role. Developing qualitative assessment tools, participating in data analysis and grant writing, as well as in grant administration. The image that you're looking at is a announcement for a CDC-funded project to implement second-tier gene sequencing for newborns who have a positive screen for severe combined immunodeficiency. So the New York State Newborn Screening Program was awarded this funding from HRSA. My role was in participating in writing the grant and developing the concept behind the grant. And now that we have the funding, my role is in administering the clinical portion of the grant, working with the immunologists who are diagnosing and treating newborns with SCID to walk them through the process, as well as complete the IRB process here at the New York State Department of Health, engage with the reporting process and test development process here, sort of from soup to nuts with implementing the outcome of this funding opportunity. Next slide, please. So Amy alluded to some of this work, but I wanted to elaborate on it a bit as well, that a large part of my time is spent on administering the New York Mid-Atlantic Consortium grant funding, and our cycle is coming to an end at the end of May, and there's a new application, and in the new application, HRSA is requesting applications for regional genetics networks. HRSA is the Health Resources and Service Administration, and there's various requirements in this new application to improve access and to address health disparities. So really a new focus and a bit of a shift is to really think about underserved populations and how we can improve their access to genetic services and how we can measure and know that they're receiving genetic services. So that's ongoing, and I encourage all of you to pay attention and join the conversation in your region about how these underserved populations can be addressed. There's also a focus in that application on resource development and dissemination, particularly a deliverable related to educating primary care providers about genetics. A lot of workforce issues related to the number of geneticists and genetic counselors to provide the service and interact with the community is an issue that hopefully developing some resources for primary care providers can help connect individuals to services and empower primary care providers to help as well. Telegenetics is also a big piece of the new application. So supporting genetic counselors and geneticists to provide services via telemedicine, as well as to look at quality improvement related to providing those services and collecting some data to show the impact of providing services via telegenetics. And then across the board, a deliverable related to quality improvement for genetic services and beginning to collect some quality improvement data and develop quality improvement measures. So each of these pieces will have a role moving forward and be a big piece of public health genetics as funded by the federal government. So again, I encourage you to find out more from your region and to get involved if you're interested. Next slide, please. So another role which is important, many states have a chronic disease program. They will coordinate a state clinic or coordinate and create a state program. Genetic counselors can have a role in those clinics, in the organization, or in actually interacting directly with patients. So that's an important, more direct service role potentially for genetic counselors. Next slide, please. Actually, I think we've got the poll, right, Kunal? Yes. Okay. Do you want to go ahead and do the poll? Got it.
Yes. So we have one final poll. While we wait for the results, should you have any questions or comments, please feel free to type in the question box in the control panel. Thank you. All right. What do you think about this result, Beth?
Yeah, I think that all of these are great resources, and it looks like there was a lot of interest from the audience in these resources. If there are specific questions or help finding resources on those sites, I'm always happy to be available to help people with that.
Right. So we have one question from the audience. The question is, do some states offer newborn screening through private laboratories? If no, why not? And if yes, why aren't all newborn screening programs run through private agencies instead of the state? So the question is for both of you.
Go ahead, Beth.
Okay, let me take that one. So there is a couple of states that use a private laboratory to perform their testing. I think each state has to look at costs and benefits of having the program in-house versus having the program at a private laboratory. You know, it sounds like maybe the question asker was thinking it may be more affordable to do that route, but that's not necessarily the case in every state, depending on your infrastructure and the number of babies that you're screening, I would think would come into play. I also think that there's a lot of value behind having a follow-up program that's working closely with the laboratory. So we're in the New York State Newborn Screening Program. I am very integrated with the newborn screening laboratory where the testing is being done and with the research scientists that are performing the testing. So we can have dialogue about the abnormal test results, about how we can improve the panel. So for example, if they're looking at changing the cutoff, but there's a baby who screened positive that they're concerned about, I can give an opinion and also interact with the clinician in a meaningful way about what it would mean to change that cutoff and whether or not that newborn would be missed. So I think, to make a long answer short, that's a complicated decision that each state has to make for what meets their needs, but that there are some benefits besides just cost and that come into factor. I don't know if Amy has anything to add.
No, I think that was a great point. And I think the other thing that I would mention is in terms of whether a private company would come in and take on all of the screening. You know, all public health programs, we are nonprofit, so we really keep the cost to what it costs to run the test, as well as all of the associated parts of the program. So the cost usually is, I think, often less than what you would see in a private company. And I guess just to elaborate a little bit on Beth's point is that newborn screening itself is much more than just the test in the lab. It's an entire process that really starts prior to the baby even being there with education, making sure that the hospitals know how to collect the specimens and ship them to us as quickly as possible, that we can turn the results around as quickly as possible, and then provide follow-up services for the family. So it helps to be in the public health realm for a lot of those other pieces, especially if you're looking at maternal and children and youth with special health care needs, and kind of some of those other services that we can pull in for families. So I think that's why, generally speaking, programs themselves as a whole have remained in the public sector and not gone to the private sector.
The supplementary comment was the issue is billing, insurance reimbursement, etc.
That, you know, certainly billing is always, I think, an issue. There are CPT codes for the various newborn screening tests that most states run. So it kind of depends, I guess, on how the hospital decides to bill for newborn screening. Some roll it into their DRG, and that may not provide them with the best reimbursement as opposed to billing separately. And I know for some of our other conditions that are not done for the blood spot, so some of the newborn screening conditions are done within the hospital. So hearing screening and the pulse oximetry screening that looks for heart disease. At least for the pulse oximetry screening, there is not a CPT code, and I know that has been an issue. For billing issues outside of hospitals, so if we're talking about out-of-hospital births, we at least have worked pretty closely with our midwives to help them at their billing. Though for certain populations, let's say the Amish, for example, we will actually waive the fee of the card in order to make sure that those children can get screened without having insurance. So those are kind of some of the programs we have in place to deal with billing and reimbursement, but certainly that is an ongoing issue within newborn screening and something that the community talks about fairly regularly about how to maybe improve reimbursement for this mandated test.
Great. Beth, would you like to add anything to this?
No, I think Amy's answer was great. New York is a little bit different in that we do not bill or charge specifically for the newborn screen. It's a public health provided service. So I'm not as integrally involved in that aspect as Amy is.
I think we can take one more question, and the question is, are there enough genetic counselors in the United States to take on the tasks associated with public health needs?
No. No, I mean, I think that that's a great question, and I think that that is something, though, that we definitely need to think about. Not only is there a shortage, I think, of genetic counselors, especially if we're looking at expanding to population-level screening, whether it's cancer or newborn or pediatric. So not only is that an issue just with genetic counselors, but geneticists we are, I would say, in a crisis mode for MD geneticists. They are exceedingly rare. Fewer and fewer individuals seem to be going into that realm, and so I would say there is a shortage of genetic-specific practitioners across the board. I don't know, and Andrea, I don't know if Andrea's on or if Beth wants to also talk about that, but at least that's my opinion. I feel like we have a shortage for sure.
This is Andrea. I would agree with everything you said, Amy.
Yeah, this is Beth. I would too.
And in addition,
Sure.
on the other side of the fence are, there aren't a lot of public health practitioners who are knowledgeable about genetics. And so I think we need to build up the workforce on both sides.
That's a great point. I think in the interest of time, we'll conclude today's webinars and then proceed with the educational activity with the LEND trainees. So I want to thank our speakers and Andrea for their valuable insights today, and thank you all for joining today's webinar. Just a quick reminder, if you could kindly complete the evaluation form after you exit the webinar, it would really help us in working and improving our educational activities. So thank you once again all for your time today. LEND trainees, please stay online.